It's the Pain Exam Podcast with your host, David Rosenblum, MD. If you treat pain or have an interest in pain management, join us as we discuss painful disorders, alternative treatments, practice management, and more. Be sure to subscribe to the Pain Exam newsletter at painexam.com and review the podcast on Stitcher or iTunes. Our high-yield premium episodes are now available on the Pain Exam app with a premium subscription or access for free with a CME subscription at painexam.com. And now, without further ado, here's your host, Dr. Rosenblum.
Good evening. I wanted to thank you all for joining us. Today, we're fortunate to have Rachel Trobman from Upside Health joining us again. She's been on the podcast a few times, and she's always a wealth of knowledge. And most recently, I was at West Virginia SIP, and their head, Rudy, was just singing her praises and telling us how it's going, his journey, implementing the remote patient monitoring into his practice. Before we get into the wealth of knowledge she's going to share with us, I just wanted to just do some housekeeping and remind you guys that we have a lot going on with NRAP. We have Regenerative Medicine, May 13th. It's a hybrid course. So if you can't come to New York, we have a Zoom component. Unfortunately, you won't be able to hang out while we process some PRP, but at least you could get the knowledge at part and claim some CME credits. We're also doing ultrasound courses. I just opened up a course in Puerto Rico in February. Hope to see you there. And board review I'm doing with Al Abdul Saeed in June. It's a hybrid ultrasound and board review course. Day 1 and 2 is going to be live board prep. Day 3 is on-demand board prep, and the alternate group is doing live ultrasound training. You could scan the QR code if you're interested. And we also have New York ultrasound workshops, and you'll get CME credits as well as an atlas going over the content so you can implement ultrasound into your pain practice. And lastly, you guys can claim CME credit, not for this talk, but for reflecting on what goes on today. There's a new rules with CME, and you actually can claim a credit, and you just scan the QR code. There's a $15 processing fee, but you'll get an actual credit. With that being said, I'm going to share the screen with Rachel. Let me just stop my share. Okay. Rachel, give me 1 second.
Should be loaded on my end.
Yeah, I think I see you on my end. I just want to make sure that you have the full control.
I do.
Okay, great. Okay, if anyone can't see anything on Rachel's end, her PowerPoint, just let us know, but I see it very clear.
Great. Well, I wish I had the need to learn ultrasound techniques so I could join you all in Puerto Rico. So thanks, David, for having me again. It's always fun to chat with you, even when it's about some challenging or changes that are underway. So I wanted to speak today with you. First, just a quick notice. As always, everything I'm talking about today is for educational purposes only. It is not any sort of guarantee of reimbursement or any sort of legal guidance. This is all primarily from my own research and then personal experience from leading a digital health company in this space. But returning back to the end of the public health emergency, the CMS and the FDA have all instituted a transitional policy that goes from just a few weeks from now into 2024 and beyond. And while there are many, many changes that come through the end of the PHE, for the sake of today, I'm really going to be focusing on ones that could have the greatest impact or greatest awareness for those running pain practices or affiliated with pain, spine, neuro practices. So the changes are kind of broken into 3 areas. One is clinical, so changes to potential clinical workflow, procedural workflow. Second is device and digital therapeutics. If any of you are using them in the practice, and I'll discuss what you should be aware of in that regard. And then the last area is telehealth. And then I will speak about the opportunities that still remain and how your practice can help take advantage of them. So starting just a few weeks from now, the May 11th are the first set of changes that go into effect. The two that I wanted to talk about a bit is changes to teleprescribing of controlled substances. So their waiver was removed. There was a waiver in place that was allowing teleprescribing, pure teleprescribing of controlled substances during during the PHE. And that meant no in-person component ever, which is really different from the way that most practices are prescribing. This was really more for the telehealth only companies. And so the changes to the waiver being removed should not have impact on most practices, because as long as you continue to have an existing in-person relationship with the patient, prescribing every couple of visits through telehealth is not a problem. And even the DEA proposal, which was just put out but has not been confirmed, to solidify that teleprescribing only is not allowed, that still should not impact typical practice workflow. The other big change, the CRNA waiver that allowed all states, regardless of whether or not they have different protocol, to allow CRNAs to practice without direct supervision, that is going to be eliminated. Now, there are...
I interrupt you for a second?
Yeah, totally.
I'm in New York. Not too many I don't know any CRNAs practicing pain management, especially, I guess, in the form where they're in a clinic and prescribing opiates and have to be supervised or less supervised with this waiver. I don't know if any of you guys listening experience this in your states, but not a very common thing in New York.
Yeah, I mean, I think this was more in regards to procedural in the states where it may happen, that they cannot be operating independently anymore, unless you're in one of those 21 states. Again, not sure. It could be impacting some practices across the country. So I did want to draw attention to that, but it's good to know, particularly in New York, it's not an issue. The second set of changes are around device changes. So during the PHE, the FDA made it easy for any software device, so think apps, that were claiming to be therapeutics for psychiatric disorders to be fast-tracked without regulation. But starting this November, they're really going to be cracking down on that and making all of those companies that said, yeah, go ahead, use our app for the treatment of psychiatric disorders and you can bill for it. All those companies who don't have official FDA clearance are going to have to go through it. So if there's a company that's coming to you and saying, my app can be used as a standalone digital therapeutic for the treatment of depression, and these are the codes you can bill, you want to verify that they're going through the actual process to get that 510K or de novo. There are currently only four fully cleared software as a medical device, digital therapeutics for the treatment of psychiatric disorders. And there's two for SUD or opioid misuse disorder, one for ADHD, one for PTSD, and one for insomnia. Again, it's probably not the full regard of what you're doing, but even if it's adjacent, I think it's important to know.
Sure. I wonder if there's going to be a clawback for those other companies.
I don't think so, because they were
Right. It was permitted. They were just more lax with the
It was
rules.
permitted, exactly. And so what they're trying to do, though, because they want to have this fully documented and fully regulated, is that they're making all of those companies now go through the full process, pay all the fees, show all the clinical efficacy to get their official clearance. But it's still just to be aware that those changes are in effect. And then the CMS kind of punted down the road telehealth changes to December 31st, 2024. And those are all of the reimbursement parity, site location flexibility, rural, not only having to be rural to be conducting telehealth. And so telehealth practice, as you're currently utilizing it across the board, continues to be fine. And it does seem very unlikely that there's going to be major overhaul in the future to completely eliminate it like the way it was before. The other change that would be changing in the telehealth and device spectrum, but it doesn't really impact RPM, and we're going to get to that, is the changes in general supervision versus direct supervision that used to be required. And that brings me to, does RPM coverage change at the end of the PHE? No. RPM, remote patient monitoring, and its two arms, remote physiologic monitoring and remote therapeutic monitoring, continue to be covered and reimbursed with the end of the PHE. And remote therapeutic monitoring, previous to this year, was only available under direct supervision, which made companies like ours not be able to provide those services, except during the PHE, it was allowed. But this year, CMS changed the rules and said it can now be under general supervision. So this change doesn't impact the way the services are rendered. The one caveat to changes is Cigna, which said that effective May 11th, 2023, they will no longer be covering RTM under any circumstance. And they will only cover remote physiologic monitoring for very specific use cases, none of which are pain or musculoskeletal. And like it has to be like congestive heart failure. And I forget, there's two other very specific use cases in which Cigna is covering it. But that comes at a time where more and more commercial insurance, we're seeing the opposite happen, where they're expanding their telehealth coverage. I also haven't seen any Medicaids who are changing their policy at the end of PHE as a result of, as it relates to RPM coverage. And so, because these opportunities continue to exist and continue to, many practices have either started experimenting with them or were concerned to experiment with them because they were worried that the policy would change as COVID came to an end. I wanted to take a few minutes to talk about how you can most successfully deploy these kind of solutions safely, smartly, cost effectively, legitimately within your practices. So kind of best practices for RTM practice. And this is kind of what the digital tools, I don't know why I said direct supervision. It should be general supervision. I've been traveling a lot. And you want it to be fully integrated. So the best practices, first best practice is make sure that you're working with a real device on a real company. And I say that because where there's opportunity, there can sometimes be volume of vendors. And I know how exhausting it can be to like weed through all of these pitches that you're getting. So, do a little bit of research, speak to friends, and I'll get to that later. But also for it to be remote physiologic monitoring or remote therapeutic monitoring, the device that is collecting the data must be a medical device as defined by the FDA. In physiologic monitoring, it must gather physiologic data. So in most cases there, it is hardware. And in therapeutic monitoring, it can gather patient-reported data, passive data. It can be a hardware or it can be a software. But the software must be software as a medical device. And so if a company comes to you and says, well, yeah, the data that we use is a Fitbit, a generic Fitbit, that's not a medical device, that's a wellness device. If the company that you're working with says the patients track this on an app, and the question is, okay, have you gone through the process to get a letter from the FDA that says you qualify a software as a medical device?
Says the Apple Watch doesn't count, correct? That's
Yeah,
like a fit, right?
So, well, the Apple Watch is a little bit of a gray area because the Apple Watch has paired with Cardia, which is a physiologic measure. But no, the Apple Watch, like a general consumer Apple Watch. There are some Samsung watches, I believe. I can share maybe later a complete device list that constitute, but they're expensive. And that's reliant on the fact that the patient already has one, which is not really a solution. The second thing is really make sure that your vendor understands and can explain to you their proposed patient enrollment and clinical workflow. We don't want is somebody to just say, yeah, you just introduce it and it works. Then that question of like, will patients use it and will my doctors know how to prescribe this is a complete legitimate one, and it's not going to be easy. And so you want a company that can show you how this integrates with their EMR, maybe do a screen share and show you how they've done it in previous instances. And if it's not exactly your EMR, but it's enough well-established EMRs, you can kind of understand that they can do it. And you also want to know what their patient enrollment process is. Is it they hand out a postcard and that's it? You really want to dig into that because that's going to be the difference of strain on your team. And I've had a lot of now current clients or prospective clients come to me and say, well, this won't work because this is what happened. And I was like, it makes me frustrated sometimes because I hate that somebody had to go through a bad experience.
I guess, how do you get patient buy-in?
So we have a lot of process to build patient buy-in. So some of it is what value you truly believe you're bringing to the practice, or the program is bringing to the practice, and how it's going to change the course of action. We tend to share a lot of other patient success stories and clinician success stories so they can have concrete examples of how the integration of these programs have changed patient care and have changed clinical experience. And then I'll share one of those in a minute, just because it's like a very concrete example. A lot of what we do is have the doctors create videos that we help them create. So that way that can be distributed multiple or every time to the patient in the same way. So that way the doctors aren't remembering a script of value. We do a lot of enrollment support and hands-on, walking the patients through the process. It's very time consuming and requires a lot of operational efficiency on the part of you, but that should fall on the vendor, not necessarily on your practice. And so if you have a practice that's going to rely heavily on you to complete it, that's going to be really tough. But what you should have is a practice or a vendor that is going to work with you to create the messaging that's most appropriate for your patient population. You also want a vendor that's transparent about pricing. How are they going to price you? Is it per patient per month? Is it a SaaS model? What happens if X number of patients don't come on?
Is the
So,
pricing per patient?
so we actually have two different pricing models. We actually do now a SaaS tier-based pricing model, but it's based off of patient volume. So we look at your practice population, shave it down, and then be able to say, for the first 3 months, let's anticipate this percentage of patients. And so that way, as you get more of those patients, your cost per patient goes down. But again, there are other arrangements where we work out per patient per month or whatnot. And then getting some, a little bit of visibility into their billing experience. So who have they billed so far? Do they have EOBs to support that process? What happens when a claim is denied? Have they worked with billers? So I think that just understanding that any vendor who offers to speak directly to your billers, if you're comfortable with, that'll help a ton. And then referrals, right? Have your friends use them. I mean, it meant a lot to me that, Rudy was talking about his positive experience, because I could talk to Lumblue in my face about our positive experiences. But, peer-to-peer referrals go a really long way. And so, I mean, I would look for the practices that are truly similar to yours, though, if possible, right? So if you're a single MD with 2 mid-levels, is there a practice similar? If you're primarily interventional, how has that been successfully deployed? If you're doing a combo of med management and that, what's some messaging that's worked? Because that similar messaging may resonate with your patients. I did want to share, before I get into questions, because I did hint at this earlier, just an example of, what kind of data and how these experiences can provide meaningful clinical care. So this was actually in Rudy's practice, I believe. And one of his clinicians came to us and said, I'm just floored by the type of insights and the relationships that your team has been able to gather from our patients in such a short period of time. And I said, well, is there anything? She said, yeah, well, I looked through the note that your team had submitted, and I discovered that one of our patients was on a patch, and the first 24 hours that they were on this medication regimen, they were doing really great. And the last 72 hours or something was impossible, or whatever. I'm getting maybe the numbers wrong. And she said, but there's a different regimen that we could put this patient on that would prevent that horrible drop off.
Are you talking about a fentanyl patch? That's a 72-hour patch, and the patient wants it every 48 hours? Because that happens a lot.
No, but the patient didn't say they wanted it.
No, but I'm saying the analgesia wore off.
Yes.
The drug wore off at 48 hours, and it was shown on your data probably.
It wasn't just shown on, so it was shown on the data, but it was also shown through the conversations and the questions that were asked with our actual nurses. And in doing that, the patient was taking less other breakthrough medication, was much more stable and consistent. And so it was just a small little anecdote of a super common thing, right? Like the clinician was able to pick up on the need for the change right away, handle it, and it's been done. But she said, I've been seeing this patient months, years.
How often does that your staff have that interaction or look at the data with the patient, or the patient's logging it every day, and then once a month they're reviewing it, right? Is that how it works?
So our nurses are reviewing it throughout the month, but they speak to the patient once per calendar month. For anywhere from 30 to, sometimes as long as 90 minutes. Instance. And so, and it's different times in the month depending on when the patient was enrolled.
Okay.
Yeah. Are there any other questions, or any questions from anybody listening in?
I had a patient that I had her on an opiate.
Mhm.
And she's been on opiates long term. I inherited her from one of my partners who retired. Pretty reliable.
Mhm.
She's actually a drug rep, high functioning woman, and she locks up her meds, has a safe. She's super reliable. And then she asked me to switch to another medication. So I rotated her, and I guess it wasn't enough. And she's going through some stress with family members, whatnot, social issues. And I guess it was a 4-week supply. And week 2, she calls me up and she's like, I'm going to be done in 3 days. I need you to help me. And I'm like, I, most people would just cut you off from opiates. I mean, what the hell are you doing? So I'm wondering if, is there some sort of way that if your people, like if she's logging that she's taking these pills, is there any mechanism to detect that she's taking more opiates than she should be? Do they log when they take the pill, or
Yeah,
how
yeah.
do?
Yeah, so we have tracking capabilities, self-reported tracking capabilities, or on their questions that we are asking as well to gauge some diversion. There are as you know, David, I obviously am passionate about what I do and our product, but I'm also really cognizant of the uh, other awesome products and solutions that are out there for specific problems. And there are some, really great medication adherence, pill bottle, smart trackers that exist and that are also RTM. Where we like to step in is because we have all of this behavioral health component and self-management support. We're able to direct the patients or be able to identify these periods of high stress and high friction earlier, and be able to identify the stresses and the trends, and hopefully be able to educate and support them so that you don't reach that dramatic inflection point like
Right.
this patient reached, but also to be able to alert or identify any changes. Okay, this patient is exactly reporting incredibly high pain levels and low function levels that are out of the ordinary. If a protocol with our nurses, if you see something like that, please report it in the EMR and text Dr. Rosenblum.
Right. Because it
The
was nice
next
to pick
step.
up on day 3 as opposed to day 15.
Right, exactly. And then asking any sort of having our also nurse reach out, have you been just confirming, what's going on? We see you're taking a lot more medication than usual.
Right.
And it's a opportunity for discussion.
Got it. Very cool.
Yeah. Well, I mean, that's really it for me today. I wanted to keep it short and informative. And I'd love to continually come on here and work with you, chat with your audience. And I also really open to hearing other subject matters that your audience, when it relates to digital health, really wants to learn more about. So feel free to reach out to David or me if there's a subject matter that you're hearing a lot about at conferences, and you'd love for someone to dive a little bit more deeply into. I'm happy to run something more specific to that. Also, if there's any way that I can help you and your practice navigate, RTM, remote pain care, and chronic pain management solutions, especially remote ones, please, email me. I think my information should be in the show notes. And
Yeah, I mean, thank you, Rich. This is a growing field, and there's more and more companies popping up that do this, as well as more and more, I think, I guess, gadgets or monitoring devices that you're going to probably see in the next few years. So this side of medicine is not going anywhere, and it's probably going to be a lot larger. And we're probably going to try to integrate this again. We definitely had we're part of an anesthesia group, so dealing with anesthesiologists and this sort of monitoring is different than dealing with strictly pain doctors. So, but everybody who I know who's been starting to do this has been giving me positive feedback. I see we have a question from Ashraf.
yeah, and the thing too, Dr. or David, Dr. Rosenblum, I've known you for so long. I don't know what is
Dave.
right anymore. We really, found our sweet spot, in working with pain practices of all different sizes, and just started working with spine pain, neurology, and ortho as well. So really being able to meet the different needs of different type of practices, which kind of works hand in hand with Dr. Salem's question in regards to do you integrate with other RPM providers that offer different services? Yes, caveat. So the question for us is, what is the product? How can it integrate into our service offering? We've worked with a heart rate variance monitor that is biofeedback, and we fully integrated within our product, but also can use standalone. And we provide all the services, all the education and implementation. The other RPM providers that we could work with would be device only. So companies that only provide the devices, and we need the service component to better support, review, and enhance. But we're not currently working with any other softwares and medical device solutions because, one, there aren't that many that are gone through the FDA process like us, but also that we think provide the type of outcomes that we've been able to drive to support our existing practices. We want to be careful that we're not partnering with a device that their technical support is not great and really shoddy, and is therefore creating more friction for our team and your team. But yes, I'd love to, if it's something you have a specific vendor in mind, please reach out to me. I'd love to discuss that with you.
We do give drugs that can cause that prolong the QT syndrome, which basically can cause an arrhythmia to the heart. And it could be a progressive thing that's asymptomatic, and then it could be symptomatic and a huge problem. So it would be nice if somebody was having some sort of EKG or heart monitoring ongoing that could give us an early warning that our drug was causing this problem. So,
well, and I think that's great. Like having specific, it's not something that we would deploy or suggest rolling out to all your patients in their practice. Yeah. Like a regular RTM solution could be meaningful, but having a specific cohort who you can tie their particular drug regimen or concern with this type of acute monitoring, I think is exactly what these codes were put into place for. And so finding those use cases, I think, is exceptional.
Yeah, that's great. Any other questions? Rachel, anything else to say? How can they find you?
Rachel at upside.health. So RACHEL at upside.health. You can check out the website upside.health for more information, or connect with me on LinkedIn. And I would love to help, again, support your practice and learn more about like what your existing challenges are or your growth goals, because I also really like to work with practices to identify opportunities specific to your care and your plans.
That's great. Thank you, Rachel. Guys, Rachel hopefully be back again in June. And if not, I'm sure she'll be on at some point later. In the meantime, just you know where to find me, painexam.com. Hope to see you guys at the courses. If not, I'll see you guys at Aspen or ASIP or NANS or one of these meetings. Take care and good night.
Dr. Rosenblum is here solely to educate, and you are solely responsible for all your decisions and actions in response to any information contained herein. These podcasts are not intended as a substitute for the medical advice of a physician to a particular patient or specific ailment. You should regularly consult a physician in matters relating to yours or another's health. You understand that this podcast is not intended as a substitute for consultation with a licensed medical professional. Copyright 2017, David Rosenblum, all rights reserved. No part of this publication may be reproduced, stored in a retrieval system, or transmitted in any form or by any means, electronic, mechanical, recording, or otherwise, without the prior written permission of the author.